Okay, we shall start on pulmonary events anomalies in continuation with the precedent talk, but you will see that pulmonary events anomaly are really fetal perinatal cardiology, pre- and postnatal cardiology is very important. We shall try to show you this importance. And why a diagnosis of anomalies of the pulmonary events is very important, quite mandatory. First, this is a type of cardiovascular medical surgical emergency in neonatology. It's really a problem of the neonatologist. I don't know if there are neonatologists in the audience, but it's really in the field, in the postnatal life, in neonatology, for pediatric cardiologists and neonatologists, it's really a problem, an emergency. It's very important to diagnose. Why? Because the presentation is very tricky. Normal pregnancy, nothing during the pregnancy generally, and right after delivery, there is a respiratory distress. A baby with a problem respiratory, and this is the problem. The problem is that this cardiac surgery, surgical emergency, is generally referred and admitted from the delivery room to neonatology intensive unit, where the pulmonary distress is taken in concern, and this is treatment. There are treatment for respiratory distress, sometimes going to membranous oxygenation, ECMO, and very intensive until someone, after days, even sometimes weeks of evolution, says, oh, perhaps it is a pulmonary vein, a total pulmonary vein anomalous return or drainage, and this is a problem, switching to the cardiology. And this is very important because it's very difficult to treat those babies when we lose time because of hypertension, pulmonary hypertension crisis, and sometimes, it's very frequent we lose those babies because of those pulmonary hypertension crisis, despite emergency, surgical emergency, and a surgical attempt. So there is a perioperative risk increased because of the late diagnosis. Exceptionally, there are chromosomal anomalies, exceptionally, deletion of the chromosome 4, for example, or familial recurrence, but the anomaly is rare, so it's difficult to make a conclusion. But why it is important to detect? Because the earlier the operation, the better the results. And so far, we organize in the structure like Hôpital Necker en Malade, where there is pediatric cardiologist, obstetrics, and cardiac surgery. We organize the birth in those institutions where it's possible to have the pediatric cardiology right in case of prenatal death, right in the delivery room, and the cardiac surgeon is ready to operate in case of what you will see, in case of obstruction of the venous return to avoid those pulmonary hypertension. So it's really neonatology. It's an example of the bridge and the relations between the prenatal life and the sonography, the general sonography. Generally, the heart is normal prenatally, so this is an example of the bridge of the sonographer, the obstetricians, the pediatric cardiology, and the cardiac surgeons. We spent a lot of works about transposition of great arteries, simple transposition of great arteries, and this is another example, very rare, but this is an example of daily neonatology and daily pediatric cardiology. Just briefly to remind you the fact of the normal four-chamber view, because we stated that there is a difference between the two ventricles. But look, there is also a difference between the two atria. This is a normal chamber view, and you recover with the with the flap of the foramen ovale indicating the atrium receiving the pulmonary veins. And you can see here the left atria, and look at the difference between the two atria. The right atria is round-shaped, and the posterior wall of the left atria is linear between the two pulmonary veins on the two sides. So there is a difference between the two atria. You can state that this is the left atria, this is the right atria because of this flap and because of this linear aspect between the two pulmonary veins. You have the mitral valve and you have the aorta here. In color Doppler flow, you confirm the left atrium with we see clearly three pulmonary veins and the fourth probably here. You have the pulmonary atrium and the aorta behind the left atrium. So this is a regular aspect of the atria of the pulmonary veins. So, in pathology, briefly, what is the problem of the left atrium? The left atrium is two parts. It's a mesenchymatous part. It's the part of the left atrium, and it's a part of a common pulmonary vein coming from the lungs and within an incorporation within the left atria. And the left atrium is those two parts, the truly left atria and the common pulmonary vein. But when you have a problem of this incorporation of the common pulmonary vein, you have possible of pathology. First, you have anomaly of stenosis of the pulmonary vein. And you can see here the two parts of the left atria with a stenotic aspect of the common pulmonary vein. And what it is, this is a core triatriatum with the pulmonary veins coming in normal place here, the common pulmonary vein, the membrane intra-atrium in the left atria, and the true left atrium which give origin to the left appendage. So you have clearly an embryological situation of this with this very rare anomaly, core triatriatum, which is a stenosis of the common pulmonary vein. But when you have absent of incorporation of the pulmonary vein, this gives you absent inflow of the pulmonary vein within the left atria, and this is a total anomalous pulmonary venous drainage. You have here, you see from a scheme from the left atria, we described exactly this aspect of the atria with the left atrium, the right, and I put here the two parts of the left atrium with the common pulmonary vein. And you can see what we showed previously with the two parts in left atrium and common pulmonary vein. In this aspect, you have a normal aspect with the pulmonary veins coming with an inflow within the left atria with the two parts of the pulmonary vein. In this aspect, you have the precedent patient with a core triatriatum with defect of incorporation of the pulmonary vein within the left atrium. And in this aspect, you have a total pulmonary venous anormal drainage without incorporation of the pulmonary vein in the left atria. There is a defect of incorporation of the common pulmonary vein. So you have a part of the left atrium lacking, and the aorta is behind the left atria, a round-shaped atrium. It's not the normal atrium. It's a round-shaped atrium, and the aorta is far, you see, above the aorta behind the left atria. And here you see the aorta far from an abnormal posterior wall of the left atria. So what is total pulmonary anomalous venous drainage? It's defect of incorporation of the common pulmonary vein inside the left atrium. Once this has been stated, another example of the normal aspect of the pulmonary veins with aorta, with the two parts of the common pulmonary vein and the two left atria. And here, total anomalous pulmonary venous return. In fact, theoretically, there are three aspects. I say theoretically because it's sometimes much more complicated. First aspect, supracardiac anomalous venous drainage, the four-vein pulmonar, which can't be incorporated into the left atria, joined to a pulmonary vein above the left atria. The four veins go to a vertical vein joining the innominate trunk and the superior vena cava. This is supracardiac form. It's above 20. It's around 50% of those forms. Second aspect, intracardiac form. It's the four pulmonary vein join a common structure and join from this common structure to the coronary sinus and the right atria. Third aspect, infradiaphragmatic aspect of those pulmonary veins. The four veins join a vertical vein, going down to the portal vein or to inferior vena cava, behind the heart and through the diaphragm. So theoretically, three types: supracardiac form, intracardiac form, and infradiaphragmatic infracardiac form. The problem of those types is the problem prenatally. Generally, all is okay, except in sometimes asymmetry of the ventricles with the predominant right ventricle, but there is, generally speaking, a good function of the problem. But postnatally, when the pulmonary veins are not in the left atria, it's necessary, it's mandatory to find a way for the blood to join the left heart, left atrium, and right and left ventricle. Sometimes there is an ASD, atrial septal defect, and there is a communication between the right atria and the left atria, leading the blood from the right atria to the left ventricle. The problem is the problem of obstruction, of stenosis of the pulmonary flow postnatally. In the infracardiac form, in the portal vein, or in the inferior vena cava, it's quasi-systematic. There is always an obstruction of the pulmonary flow. It depends after when the baby is threatened by this condition. Is it within minutes, within hours, or within 1 or 2 days or 3 days? But it's systematic. The baby, this is a life-threatening condition. And you can imagine the importance of the prenatal diagnosis of this condition. In supracardiac form, 60 or 70% are not obstructed. So the baby is okay at birth, and secondarily, there is a right ventricular overload, and the baby can cope with this right ventricular overload during days, weeks, sometimes months, sometimes years, before the diagnosis is done, like an ESD, an atrial septal defect. So, but in 25-30% of cases, the vertical vein is going through the pulmonary artery and the bronchi, and this is une pince, comme on dit une pince. There is a stenosis at this point of the vertical vein, and this is possible pulmonary hypertension. And this type intracardiac is never in stenosis, and we have time to. So, condition detectable from the prenatal systematic examination when the pulmonary veins are checked, and it's very important to detect those conditions because of pulmonary hypertension, postnatal, neonatal pulmonary hypertension. So we shall see some examples. This is the supracardiac form with this aspect of the 4 pulmonary veins in the vertical vein, innominate vein trunk, superior vena cava right atrium, and normal inferior vena cava. And here you have a photo from Lucie Louyel from Maryland Long with the aspect of the pulmonary vein describing this aspect. And you have here in echo, in fetal echo, here a vein, a vertical vein, going to the innominate vein and the superior vena cava. It's 22 or 23 weeks of gestational age. And this is an aspect of supracardiac total anomalous pulmonary venous drainage. You can see this abnormal. And you have here on the left side a normal pulmonary vein with an inflow, normal inflow in the left atria. And on the right side, you can see a pulmonary veins not entering the left atria, but describing a curve to the vertical vein we have seen precedently. So the absent inflow of the pulmonary flow in the left atria lead to the diagnosis of this condition. Without color, and sometimes you have this sign, the dilated supraductus arteriosus and supraaortic dilated innominate vein, or dilated aspect of this one. What is this dilation? This dilation is the aspect of the vertical vein coming with stenosis and aliasing toward the innominate vein trunk. This dilation is a sign for the general sonographer to see that there is something abnormal in the pulmonary venous return. So it's very important in the normal. You see a dilatation of the superior vena cava, you have to think about supracardiac anomalies. The surgery is simple. If I say that simple to the surgeon, he said to me, Pascal Way said, if it's simple, come and do this. But it's simple with ligation of this vertical vein. Second aspect, the infradiaphragmatic with a common pulmonary vein going through the diaphragm to the portal vein. And this is the life-threatening condition. What you have in echo, you are here the pulmonary vein going to the vertical vein behind the heart, and this vertical vein goes through the diaphragm to the portal vein here at this place. So this is the infradiaphragmatic flow. Another example of this, and this is the point where there is a stenosis postnatally. Prenatally, it's okay, and postnatally, you have this aspect. Other view of another patient with a vein. The aorta is here, but this vein has nothing to do here. This aspect, vascular aspect, nothing to do here. You have here the superior vena cava normal, and this aspect is going through the diaphragm to the portal vein here, and in color, the same patient with the absent inflow of the pulmonary vein. And the surgeon in this condition opened this aspect between the vertical vein and the left atria to restore a flow and inflow in the left atria. So this is a curable malformation when it's isolated. Another aspect, you can see here the stenosis. Prenatally, there is some degree of stenosis, and here you have behind the heart an abnormal vein between the aorta and the heart going to the portal vein, dilatation of the portal vein. And this is equally a sign for the general sonographer. This patient was sent by a colleague on sonographer. He said, I have an abnormal structure alongside near the stomach. I don't know what is it. And I said, look at the pulmonary veins, look just above, and just above, he saw that, Nicolas Friès from Montpellier, just above, he saw this aspect with a normal, with the pulmonary vein, the inflow to the vein, going through the diaphragm and going to this aspect of the vein. Now, sometimes it's difficult. Sometimes it's difficult because sometimes you have a lot of disposition, with several disposition of the pulmonary veins. It's called what we call miscellaneous aspect of the pulmonary veins, and you have sometimes forms really unrepairable. Sometimes you have a risk of mistake because of partial form of pulmonary vein. In this example, in this view, you have an aspect of anomalous venous return. You see, the pulmonary vein describes a curve and doesn't lead to the left atria. And the same patient, in this view, you have normal inflow of one pulmonary vein into the left atria. So when we check one pulmonary vein into the left atria, there is a risk of false negative, and it's good to see two pulmonary veins, one of each part of the heart, one right and one left, to be sure that there is no those condition. It's partial pulmonary vein, after we see. This is intracardiac aspect of vein within the coronary sinus. You can see here the pulmonary vein going into a superior left vena cava, and going not in this form. Another example, going to the coronary side, dilated coronary sinus, and you have sometimes, generally in complex anomalies, direct aspect of the pulmonary vein in here, common atrioventricular defect. Pulmonary veins are repairable when they are isolated anomalies. As you have seen by Julian, pulmonary veins are frequently associated to complex disease, especially isomerism, and it's very important to diagnose on conditions. It's very important because sometimes isomerism are very, you see, you have to bear in mind that complex anomaly doesn't mean little anomaly. Sometimes you have very complex anomalies with normal life of the babies and possible of palliative surgery. In this form of common atrioventricular septal defect with malposition of the artery, there is a risk of isomerism. but you can see that the vessels are present. The vessels are, there is a permeability of the two vessels. They are equally in size, and we can say that from the cardiopathy, AV canal with malposition of the artery, this is possibility of life at birth and life during months, even years in some cases, spontaneously without any problem and without any surgery. It's true if there is not, like in this condition, a total anomalous pulmonary venous return. And this livable condition becomes unrepairable with a terrible postoperative course, and we are quasi sure that this baby will die within months, even after surgery, despite surgery. Other type of association, here you have a coarctation of the aorta, and when you check the pulmonary vein, fortunately it is on the same slide, you have not inflow, absent inflow of the pulmonary vein within the left atria. So you have the association of coarctation of the aorta and abnormal pulmonary venous drainage. This is a well-known condition in pediatric cardiology, and the post-operative course of the coarctation is quite different in this case, in those conditions. And sometimes in anomalous venous drainage, you have, like in this case, a supracardiac anomaly venous drainage with a dilatation of the superior vena cava, and you can see here the flow with 1 meter, so acceleration, abnormal acceleration. So in this form, this was abnormal supracardiac, and this baby died from a lymphangiectasia as associated to the anomaly. So it's possible to diagnose those conditions. It's rare. Between 1988, the year we met the first time with Rabbi Shawi, until now we have around 12 cases of isolated TAPVD. But now the obstetricians, the sonographers, are looking very thoroughly the pulmonary veins, not to avoid those conditions. Just to remind you the fact of the signs leading to the condition: right ventricle dilatation, dilatation of the zone of drainage, superior vena cava in case of supracardiac, portal vein in case of infracardiac, aorta far from the left atria, one vein between aorta and posterior wall of the left atria, round-shaped left atria. All these signs in the general normal 4 chambers may lead to the possible diagnosis of this anomaly, and the direct diagnosis is direct color Doppler, absent drainage, pulmonary vein to LA. So this is a vein between the left atria, the abnormal left atria, and the aorta far from the left atria. This is a dilatation of the innominate vein. And this is a dilatation of a portal vein near the stomach. Thank you for your attention.